Hello and welcome to the fourth and final episode of the international edition of The Art of Drug Choice, Wet AMD and the Latest Data. It's my pleasure to have my colleagues from around the world here, Dr. Peter Kertes from University of Toronto in Canada.
Thanks, Arshad. Very happy to be part of this.
Dr. Justus Garweg from University of Bern in Switzerland.
Great to discuss with you all the new issues and topics.
And my good friend, Dr. Seenu Hariprasad from University of Chicago.
Thank you, Arshad. It's such a pleasure to be part of this esteemed panel.
It's my pleasure to have all of you here, and I'm looking forward to a robust discussions about real-world safety data and clinical trial safety data in wet AMD. Also, I'll share a case for the panel to review at the end. Our previous episodes covered switching wet AMD patients to different drugs, phase 3 and post-marketing data, and pipeline candidates. If you want to catch up on those, please go back and listen to those episodes. For now, let's get into our safety discussion, and Dr. Peter Kertes from Canada will update us on what's happening with brolucizumab.
Thanks, Arshad. In previous episode, we touched on the Komodo Health and IRIS registry data discussing inflammation related to brolucizumab in these post-marketing studies. And we talked about how patients with the following were more likely to experience intraocular inflammation after being treated with brolucizumab. Female gender had slightly higher rates of intraocular inflammation, history of retinal vasculitis, retinal vascular occlusion, or intraocular inflammation, all predicted intraocular inflammation after brolucizumab. And the presence of anti-drug antibodies were predictive of future IOI after brolucizumab therapy. The MERLIN study was recently halted by Novartis. MERLIN was a 2-year study that enrolled patients with wet macular degeneration who had persistent retinal fluid despite being treated with anti-VEGF therapy. The study met its primary endpoint, but there were higher than expected rates of intraocular inflammation, which led to the study being halted. RAPTOR and RAVEN, which were assessing the efficacy and safety of brolucizumab for the treatment of retinal vein occlusion, was also halted as a consequence of what was found in MERLIN.
Peter, thanks again for the great summary. Of course, you highlighted the MERLIN study, and the recently released data showed that patients had higher inflammation, almost double than what we saw in Hawk and Harrier. But of course, these were previously treated patients who received monthly injections in the first and second year. And obviously the study was halted because it appears that there's more inflammation when patients are treated monthly with brolucizumab. Justus, does MERLIN change anything you're doing in your clinic with patients with brolucizumab? I know we discussed anyways that even if we switch, we don't do the loading dose because it appears that monthly injections have a higher rate. What are your thoughts on that?
Well, basically, it didn't change anything because if we switch patients, we give them an injection and we see the patients back 4 weeks later. And if they have some residual fluid, we still give an injection after 1 month, but then we start extending the treatment interval to 6 weeks. And I have not had any patient who was not capable of being extended to 6 weeks or beyond after the first month. So I don't think the signal that was found in MERLIN is of relevance for our typical switcher patient in clinical practice.
I agree. I think, I don't load anyways, as I said earlier, so it doesn't affect, but what it tells me that we won't have a monthly label, at least in the US. Seenu, any thoughts on monitoring patients for inflammation and how this new safety data has changed how you manage patients with BOVU, considering the female gender as well as history of IOI?
Well, I'll tell you, I actually don't bring in patients just for a check for inflammation when I use brolucizumab. Rather, we have an extensive education discussion with the patient about the symptoms where they should notify us immediately. And so it's more about the discussion, and it does take some time, but we don't bring them in sooner for an inflammation check. Of course, we pay attention to the data. We certainly won't use brolucizumab monthly, to be honest, based on MERLIN, but it really hasn't increase the number of visits because of this rare adverse event that we're all concerned about.
I think those are great points. I do the same. I don't bring them for safety checks. I just dilate patients every time they're there and look for inflammation before I decide to inject. So I think that's the only additional burden I have. So let's go to the next discussion here. Dr. Seenu Hariprasad will cover some of the safety data from the TENAYA and LUCERNE studies with faricimab.
Thank you, Arshad. The faricimab safety data was actually quite good. In the phase 3 studies, TENAYA and LUCERNE, no safety signals were identified and no unexpected safety signals occurred. Only 1 to 2% of patients in either arm of both trials showed a serious ocular adverse event. Intraocular inflammation events were found in 2% of patients in the faricimab group and 1.2% of patients in the aflibercept comparator group. And there were no cases of retinal vasculitis noted in either arm.
Great, Seenu. So I think that is promising that we have not seen any new safety signals. With faricimab in these large phase 3 trials, we didn't see any new signals in phase 2 stairway or avenue studies either. As we know, the 2-year study data is still being collected and analyzed, and the long-term extension, the Avenol X study, will generate 4-year data so we can see the safety and efficacy of faricimab long-term. Justus, does faricimab bother you at all in terms of safety? Appears that it's comparable to current standard of care treatments?
I'm looking very much forward to having faricimab at hand to compare its efficacy with brolucizumab and to learn about its safety as we learned from brolucizumab after marketing of this drug.
Peter, any comments about safety of faricimab from you? It appears to me that is pretty comparable.
Yeah, certainly, brolucizumab has raised the specter and the importance of safety. So knowing that this is safe will make it, will move it into the realm of first-line therapy. And I very much look forward to comparing it to the agents we currently have.
You always have to balance the efficacy and safety, and each patient's needs are different. So I think it's great to have options as we discussed earlier. So next we're going to move on to safety of gene therapy, and Dr. Garweg will cover the safety of ADVM-022 as well as RGX-314.
So the OPTIC, which is a phase 1 trial assessing RGX-314, showed a very favorable safety profile. An ocular adverse event in 80% of cases, which was moderate in 20% of cases with mild inflammation, but no vasculitis, retinitis, choroiditis, vascular occlusions, or endophthalmitis. In contrast to this, the INFINITY trial, which is a phase 2 DME trial, was paused because the adeno-associated virus induced into one diabetic case produced a severe panuveitis with hypotony and severe vision loss. And therefore, we do not know whether it's a single case or there's more than this single case signal behind it. The RGX-314 has to be placed into the eye with a surgical procedure, which is a vitrectomy. And linked to this, it has its inherent safety concerns. If given into the subretinal space, we are still waiting to having that in the seeing its effect in the suprachoroidal space. High dosing of the drug is not advisable because of a significant decrease in vision in the high dose cohort. There were no reports of clinically determined immune responses, drug-related ocular inflammation, or post-surgical inflammation beyond what was expected from the routine vitrectomy itself. So in so far, we can look forward to that. The review of the PDS safety data at 72 weeks in ARCHWAY showed 4 cases of endophthalmitis, which is quite high, but it's not higher than what we saw in intravitreal injection treatments for DME. Some reports of the PDS implant reported dislocating from the original position, but this was in the early phase of the trial when we had not learned how to implant the thing most perfectly, and this is namely relevant for the length of the incision. If that is a little bit longer only, then the stability of the PDS is not given. Surgical guidelines were updated accordingly, so I do think this safety signal has been overcome.
That's a great summary, Dr. Garweg. I think for intravitreal gene therapy, manageable safety in OPTIC trial with no irreversible vision loss. In the Infinity trial, as you said, there's a patient with hypotony, panuveitis, and vision loss that we are still learning. I think we need to see if gene therapy acts differently in wet AMD versus DME, or is it just that as we treat more patients, we are exposing patients to these events? Anytime you have irreversible or severe vision loss, there's a concern. Just like in the RGX-314 trial, the vision loss was because of pigmentary changes going into the center, and that's why the blood location has been moved. Obviously, we didn't see any drug-associated inflammation. And then for delivery system, we extensively covered that in our prior episode. But anytime you're doing any procedures to the eye, you're looking at safety and efficacy. Seenu, any thoughts to summarize Dr. Garweg's talk here?
No, I think you summarized it very well, and it's cautious enthusiasm. I think all of us share this excitement about this new frontier of gene therapy in a disease like AMD or diabetic macular edema. But we really need to understand these safety issues, certainly not ready for prime time. And I think a lot of work needs to be done. And if I'm not mistaken, RGX may have, the patients may have received a sub-T-nonce catalog at the time of surgery. I recall that, vaguely recall that, and that might be hiding some of the information that we don't see with RGX, what we do see with Adverum. Does anyone know if that's the case? That did they receive steroid at the time of vitrectomy surgery?
No, standard of care, Seenu, so subconjunctival steroid and antibiotics. There was no mandated sub-T-nonce, but we did use topical steroids per standard of care for surgery. There are other gene therapy trials that are surgical that require sub-T-nonce injection. So I think that's a good point is, we need to learn long-term safety and efficacy data. And I think the bar is really high because we have great agents. Any closing thoughts from you, Peter?
Yeah, as I said previously, I think this realm of gene therapy is tremendously exciting. We're just scratching the surface, and so I think it's going to need some significant fine tuning. But I think the day will come where we see gene therapy treatments that are lasting, durable, and safe.
With that excitement, we are taking a short break, and we'll be right back where I'll present a case.
Hello, everyone. Welcome back. I'm taking over for Arshad because he's going to share a case with us. Arshad, take it away.
Thank you, Peter. So my case is an 83-year-old retired infectious disease doctor who was diagnosed with neovascular AMD in my clinic in November of 2010. I treated the patient with bevacizumab, ranibizumab, as well as aflibercept. He initially was on ranibizumab, but then the disease was not controlled, and that's why he was switched to aflibercept and received 19 injections, but it was discontinued due to developing severe IOI. So this patient was actually waiting for approval of brolucizumab and was one of my first patients that I treated with brolucizumab. Here you can see an OCT image before patient was switched to brolucizumab. You have significant disease activity with large amount of subretinal fluid, and this was about 6 weeks post ranibizumab. Of note, he travels a lot, so he was unable to come every month, but he would come in when he could, and this was 6 weeks after the ranibizumab injection. This is 4 weeks after brolucizumab. Again, this was one of my early cases. We were not aware of the safety signals at that time, and you can see patient has significantly improved visual acuity as well as resolution of fluid. At this visit, I did not treat him with brolucizumab. I actually don't do loading doses when I treat when I switch my patients to brolucizumab. And here you can see 8 weeks after brolucizumab, the visual acuity is still good and patient continues to have no fluid and dry retina. He was then extended. This is 10 weeks after brolucizumab. You can see The retina is still doing well, and this is 12 weeks, and you can see there is some subretinal fluid and disease activity. So we were able to figure out his treatment interval, which was about 8 to 10 weeks, and that's what he was maintained on. But this is his OCT after 9 weeks post fourth injection of brolucizumab. Visual acuity was still good, and fluid was controlled. Here he was treated with fifth brolucizumab, and then he showed up 3 days later with severe intraocular inflammation. He actually had a hypopyon, and his visual acuity was count fingers. Obviously, in a patient with this finding, he did not have any pain. We were concerned about endophthalmitis, and we offered him a tap and injection. And obviously, he's a retired infectious disease doctor. He said, this is very similar to what I had with aflibercept in the past. I don't want to have tap and inject. So he did not receive that. He was started on topical as well as PO steroids, and he improved slightly, but not significantly over the next few days. And at that time, I was able to convince him to undergo a vitrectomy with culture. We performed the vitrectomy, we cultured, the culture was negative. I was happy to see that there was no vasculitis seen intra-op after the patient was treated with vitrectomy. His visual acuity returned to baseline, and he had no vasculitis. So this case really highlights that patients with prior risk of IOI are actually at risk of IOI with brolucizumab. Now, again, this was a case that happened before the IRIS and Komodo registry data that we are all aware of, which has shown that patients with IOI, patients with history of retinal vascular occlusion are at higher rate of those with treatment with brolucizumab. So I would love to see what the faculty has to say. So I'm going to hand it back to Dr. Peter Kertes.
Great case, Arshad, and reassuring to hear that despite some intervention, the patient returned to their baseline vision. Seenu, do you have any thoughts about this case, and have you had similar experience with brolucizumab?
Fortunately, I have not had an intraocular inflammatory event with brolucizumab. But what I see in this case is the importance of understanding clinical trial data. From what I understand, Dr. Khanani didn't have the advantage of seeing the latest data that was released about ocular inflammation when he had used brolucizumab in this patient who already had a history of intraocular inflammation. But now knowing what we know, I don't think anybody on this panel would have used brolucizumab in a patient that had a history of intraocular inflammation. So it's just, it stresses the importance of being up to date with the trial data, retrospective studies, and really the pulse of what our colleagues are doing in the community. But really wonderful case, and stresses the importance that we should not use brolucizumab in a patient that has any history of intraocular inflammation.
Justus, do you have any thoughts about this particular case?
Well, we have similar experience, but not with going to vitrectomy. We treated our patients aggressively with systemic corticosteroids in the first days intravenously, and we had also very, very good outcomes, which means the drug was effective despite the severe inflammation we observed. The critical point is probably early diagnosis and aggressive treatment to prevent further vascular occlusion and to control intraocular inflammation.
Arshad, I have a couple questions about this particular case for you. When someone has intraocular inflammation and gets brolucizumab, we blame it. We tend to blame it on the brolucizumab, and that may very well have been the case. But of course, these are intraocular and intravitreal injections. They can certainly get endophthalmitis. It's certainly, when I first looked over this case, I would have gone with endophthalmitis first and either tap and injected or done a vitrectomy. We know that in endophthalmitis they often don't grow things, even though we know it's infectious. You alluded to the fact that you were leaning towards intraocular inflammation versus endophthalmitis with the help of a colleague, but I still think that this may have been infectious rather than pure inflammation, just by the way it presented and how you described it.
No, I agree completely with you, Peter. We actually offer tap and inject right away but the patient is an infectious disease doctor himself, and he said, this is very similar to what I had with aflibercept in the past. So he actually refused tap and inject at that time. The findings that we saw, there was no fibrin in the anterior chamber, which has been associated with more infectious versus non-infectious sterile endophthalmitis with aflibercept. And I saw him when he had that inflammation episode with aflibercept, and his eye looked exactly the same. But what concerned me was that I did treat him aggressively with steroid topically and systemically with high-dose PO steroids, as Justus mentioned. But my clinical judgment was that in other cases that I've seen, a patient recovered quicker than him. So I was still concerned about endophthalmitis, actually. So that's when I said, we're going to find out what it was. Even if culture is positive or negative, you're going to do a vitrectomy, you're going to get recovered vision. My main concern was not getting vasculitis, because we know that if you don't control inflammation with brolucizumab, acutely, you will end up with irreversible vision loss. And I think that's what happened in the trial. So I think here now we have information that if your patient is on brolucizumab, you have to intervene. Now I actually use intravitreal dexamethasone on top of systemic and topical steroid in somebody that has severe inflammation. I have not had a single patient with irreversible vision loss because of that management strategy. So I completely agree with you. Infection was top of the list, but when patient doesn't want to do an intervention, I didn't have a choice, but he did agree on vitrectomy. And, the bottom line is he didn't end up with irreversible vision loss, which is something we want to avoid. We did serial fluorescein angiograms, as you saw in the talk. There was no vasculitis. So I think the patient ended up with a good outcome. And remember, this case was actually before we learned about the iris and Komodo. So this is one of my early patients who was actually waiting for brolucizumab to be approved. So I think this was a learning case for me, and this was before the data you presented very nicely, Peter. But now, as Seenu mentioned, I don't use brolucizumab in patients with history of IOI with any other agent.
Thanks, Arshad. There's a lot of lessons to be learned from that case. So what's next for this patient? He's had an inflammatory reaction from aflibercept and brolucizumab. He still has active AMD. What do we do? What do you do now?
So he actually is on ranibizumab again, but his need has gone down since the vitrectomy. And now he's on every 8 to 10 weeks ranibizumab with good control. So I don't know what happened in terms of disease modification or control, but he's actually very happy and controlled on ranibizumab, and his BCVA continues to stay same as before. So he's actually very happy with the outcome. Obviously, we don't want to go through this outcome in other patients, but he's doing well.
Thank you for everyone for joining us for this, the final episode in The Art of Drug Choice. Please go back and listen to some of our other episodes in the podcast, and check out the images that are available from these cases on itube.net. Thanks for listening, and thanks for joining us.